Hi, my name is Dr. Daniel Petrylak. I'm Director of Genitourinary Oncology at the Smilow Cancer Center at Yale University. I'd like to talk today about genitourinary cancer. These are cancers of the urinary tract and the reproductive organs, so that comprises of prostate, bladder, kidney, and testicular cancer. When prostate cancer spreads, it typically spreads to the bone. The manifestations of the spread of prostate cancer can include bone pain, a rise in PSA, weight loss, or fatigue. Generally, the way this is treated is with hormone therapy. Prostate cancer is stimulated by the male sex hormone testosterone, and depletion of testosterone will cause prostate cancer cells to arrest and to die. Unfortunately, this is not curative. Generally, after about 2 to 3 years, the patient demonstrates progression. In other words, the cancer gets worse, and that's measured by a rising PSA or changes in bone scan or changes in CAT scan. That's one of the most common times when a patient sees an oncologist. We have many new therapeutic options for what we call castrate-resistant prostate cancer, which is patients who failed after hormonal therapy. In 2004, 2 papers in the New England Journal of Medicine demonstrated that chemotherapy with a drug called docetaxel improved survival by about 3 months in men with the most advanced form of castrate-resistant prostate cancer. And for a number of years, we had no other options aside from docetaxel. Right now, there are 5 drugs or 5 procedures that are either approved by the FDA or about to be approved by the FDA for this form of castration-resistant prostate cancer. Several of these drugs use the concept that even though the blood levels of testosterone may be low, that the prostate cancer cells have adapted and make their own testosterone. So we are now using a drug called abiraterone before chemotherapy to lower testosterone levels within the prostate cancer cells. And that has been shown to delay progression in patients who were treated before chemotherapy and also improve survival in patients who were administered this drug after chemotherapy. Another drug called MDV-3100, otherwise known as enzalutamide, was also recently approved by the FDA for patients who failed chemotherapy. It uses a very similar concept of preventing the target of testosterone, which is the androgen receptor, from causing its activity. And it blocks that target from going to its site. Survival is improved by about 5 months overall in men who are treated with enzalutamide. One of the more exciting areas that I've seen in prostate cancer research has been the recognition that immune therapy plays a role and is active in castrate-resistant disease. Provenge, which is a immune product, it's made from the patient's own immune cells and is targeted against something called prostatic acid phosphatase, which is a marker that's present on human prostate cancer cells. The patient has their blood cells removed. The cells are activated against this target and then given back to the patient 3 to 4 days later. This also shows an improvement in survival with minimal toxicity. Another drug that's in development, which may be approved by the FDA this year, is a drug called RAD223. This is an isotope or radioactive agent that targets bone. What's unique about this particular agent is that it has minimal toxicity, and for the first time, we're seeing a survival benefit in patients treated with this drug compared to placebo. So this is really another way that we can potentially treat patients with castrate-resistant disease. So we have hormone therapy, immune therapy, chemotherapy, and radioactive isotopes. All of these are part of your doctor's armamentarium to treat your cancer.